So good morning, it's 8 o'clock. I think I'm going to go ahead and get started. My name is Debra Suter. I'm the director of the Voice and Swallow Clinic at the University of Kentucky. And what I'm going to talk about this morning is the Yale Swallow Protocol, which is a screening protocol for aspiration risk that I co-developed. In terms of disclosures, I do collect royalties from Springer International Publishing for a book entitled The Yale Swallow Protocol. I have royalties from Team of Medical Publishers and then from MedBridge. In terms of non-financial, I have nothing to disclose. So I thought we'd start by giving a little bit of background on dysphagia in general. We know that dysphagia affects approximately 9 million adults each year. And my clinical practice does focus entirely in adults, working with adults. So certainly we know that children and infants can be affected as well, but in terms of adults, 9 million are affected. Dysphagia is associated with a 40% increase in hospital length of stay. And we know that the overall cost to hospitals for caring for individuals with dysphagia is as much as $10 billion annually. Patients with dysphagia are approximately 4 times more likely to be readmitted to a hospital within 30 days of discharge. So it's a huge problem, it's a costly problem, and it can result in increased lengths of hospital stays. It can result in multiple hospitalizations. Aspiration pneumonia is the thing that we're all trying to, as clinicians, to prevent our patients from developing. It is a potentially severe complication of undetected dysphagia. It's one of the leading causes of death in older individuals, and it's, again, quite costly. The costs per occurrence for caring for individuals with aspiration pneumonia range anywhere from $19,000 to $25,000 per occurrence. And you can see those data are considered old at this point, if you can think of 2003 as being old. So certainly that cost is increasing with time. So why are we talking about screening at all? I want to first off differentiate between screening and a diagnostic test. So when we talk about dysphagia or swallowing disorders, when we're talking about diagnostic tests, we're talking about things like instrumental assessments of swallowing. So for instance, video fluoroscopic swallow studies or endoscopic evaluations of swallowing. When we're talking about dysphagia, that's what I mean by a diagnostic test, and certainly there are others. But diagnostic tests are used when an individual is suspected of having a condition. So when we ask to complete a video fluoroscopic swallow study or an endoscopic eval, or you ask us to do that, we already suspect that the individual has dysphagia and or is aspirating. The purpose of a diagnostic test is not to tell you whether definitively the person's aspirating or not. The purpose is to confirm or rule out dysphagia. So we're interested in determining swallow pathophysiology. So why is this person aspirating, and what can we do to treat the underlying cause for why the individual is aspirating. Screening tests, on the other hand, are given more broadly. They're given usually to groups of asymptomatic individuals to determine if any of them have the condition in question. So again, in this case, it could be dysphagia, it could be aspiration. I'll return to that concept because they're two different entities, two different conditions. And we need to be clear when we're completing a screening what it is that we're screening for. When we screen, we can screen everyone in the population if that's considered appropriate, or it's considered acceptable to take a more individualized, what's called a case finding approach of people at high risk for a condition. So for instance, it may not make sense to screen every individual who enters your clinical practice or who enters an acute care setting, but it may make more sense to say, okay, if an individual is admitted and they have a diagnosis of stroke, for instance, we know by virtue of their diagnosis, they're at higher risk for having dysphagia and or aspirating. Therefore, we're going to screen every individual who comes in who's had a stroke. So that's considered acceptable when it comes to screening. Screens should be quick. One of the reasons that we do a screen is to save time. Not everybody needs a full instrumental assessment of swallowing. Instrumental assessments of swallowing can be quite time consuming. Anytime you've tried to schedule a patient, or we try to schedule a patient, certainly there's a lot of time involved in getting that patient scheduled and getting them, for instance, to the fluoro suite. Screens should save you time. They should be quick. They should be easy to administer as well, and they should be inexpensive. We want to save money. So otherwise, why would we not just do an instrumental assessment on everybody? We want to save money by doing a screen. They should be inexpensive. They should be less expensive than the diagnostic assessments that are available to us. We also want to make sure that screens have a high sensitivity. What I mean by that is you don't want to have a high rate of false negative responses on a screen. You don't want to miss individuals with a screen. Conversely, when it comes to screening, at least, it is considered acceptable to have a high rate of false positive responses, meaning that screening tools often will have lower specificities, but you want a screening tool that has a high sensitivity. So again, screenings need to be quick, they need to be easy to administer, they need to be inexpensive and have high sensitivity. The American Speech Language Hearing Association, which is our, as speech pathologists, the association that governs our certification, defines swallow screening as a pass-fail procedure. And right there, that's one way that we differentiate that, a swallow screening from a diagnostic assessment. Video fluoroscopic swallow studies and endoscopic evaluations of swallowing are not pass-fail procedures. Again, they are procedures used to identify swallow pathophysiology. So why is this individual having swallowing issues? Is it a breakdown in, is there a structural issue? Is there a physiological issue that's causing this individual to have difficulty swallowing? That's not a pass-fail. Screen is a pass-fail procedure to identify individuals who require a comprehensive assessment of swallowing function. And what a comprehensive assessment of swallowing function is, it's going to be individualized. For some individuals, it may mean that they need a video fluoroscopic assessment. For others, we may suggest the endoscopic assessment of swallowing is more appropriate. In other cases, neither one of those may be the appropriate assessment, and we may suggest referral to other professionals or other medical services. Certainly ENT, in some cases, we may suggest that the individual should see gastroenterology. So again, screening pass-fail, it's designed to determine who needs a full assessment and who does not. According to ASHA, screening has 3 different purposes. One is to determine the likelihood that dysphagia is present. When I talk about Yale swallow protocol, I'm going to talk about we are screening for aspiration risk. Dysphagia and aspiration, again, are 2 different entities. Aspiration occurs as a result of dysphagia, but an individual can have dysphagia or significant swallowing problems, but not necessarily aspirate. So we need to be clear when we're assessing or when we're completing a swallow screening, what it is we're screening for. Is it dysphagia or is it aspiration risk? Dysphagia, again, is swallow pathophysiology. So it's things like reduced hyolaryngeal excursion or reduced base of tongue retraction, So it's issues with bolus flow and timing and structural movements. I would argue that a swallow screening cannot give us that information. So my argument would be that we're screening for aspiration risk. One of the other purposes of swallow screening is to determine the need for a formal swallow evaluation, as I said. So that may mean an instrumental assessment of swallowing. It may mean something else. And the third one is to determine when it's safe to recommend resumption of oral alimentation. Certainly that's the big question. If you're working in an acute care setting where an individual comes in, they're on a non-oral means of nutrition, we want to know if they can have oral medications. We want to know if they can have an oral diet. Screening is one way to make that determination. So why should we screen? Video fluoroscopy is considered to be the criterion standard, and I deliberately didn't call it a gold standard because we don't have a gold standard in terms of assessment of oral pharyngeal swallowing function. Certainly, it is considered the best means. It's the only instrumental assessment that affords us the ability to see oral, pharyngeal, and the cervical esophageal basis of swallowing, but it's not necessarily appropriate for all individuals. FEES also has its merits. Flexible endoscopic evaluation of swallowing has its merits. And they're both great examinations. They both give us very valuable information, and certainly they need to be utilized when appropriate. But why wouldn't we just do an instrumental assessment of swallowing on everyone? Well, first off, it's expensive to do those procedures. Not every individual needs those procedures. I'm sure you all have encountered at this point difficulty scheduling patients. Video fluoroscopy, for instance, for us often means that we have to wait at least a day or two in order to get the individual scheduled in the fluoro suite, so that delays the assessment of swallowing for some individuals. It also means there's a delay in resumption of an oral diet if the individual, it can be deemed to take, it's safe to take an oral diet. There's a delay when you're waiting to get into the fluoro suite. It involves transportation to the fluoro suite. So if you have somebody who, for instance, is in a skilled nursing facility, again, there's a delay in time there. And I think we could all agree it's not a proper utilization of resources to do an instrumental assessment on every single patient who walks in the door. We need to have a way of judiciously determining who does and who doesn't need this full diagnostic assessment. And that's what screening is. It gives us a way to determine who needs a full assessment and who we can say, you know what, I think you're safe. I don't think we need to do a further assessment. We are going to, based on this screening tool, make the educated assumption that you're safe for an oral diet based simply on a screen. There is evidence that the risk of pneumonia is 11 times higher for patients with severe dysphagia and aspiration. And there is evidence, again, that when hospitals utilize a formal and mandatory dysphagia screening tool, they have lower pneumonia rates than hospitals that do not implement a similar procedure. So screening has benefits. It lowers costs to hospitals, which certainly is a huge benefit of screening, but it also reduces length of stay for individuals. It also helps to improve quality of life for our patients because they're not having to wait for prolonged periods of time in order to have an oral diet, in order to have oral medications. So there are a number of benefits of screening. Which brings me to the protocol that my colleague and I developed called the Yale Swallow Protocol. And it's called the Yale Swallow Protocol because it was, again, developed with my colleague, Stephen Leader, who was a speech pathologist at Yale New Haven Hospital in Connecticut. And so what he and I did was we sought to develop a protocol for identifying individuals who were at risk for aspiration. We were very clear from the get-go that neither one of us thought that based on a a screen that could be done at bedside without the benefit of being able to visualize particular aspects without x-ray vision, for instance, for video fluoroscopy. We were very clear that at best a screen could tell us about aspiration risk. It couldn't tell us about dysphagia. So from the get-go, we determined that we wanted a protocol that could identify individuals who were at risk for aspiration. The goals of our research were to develop a valid and reliable screening tool for determination of aspiration risk. We wanted to develop a screening tool that could be used across a number of healthcare delivery settings. So it wasn't enough to say that we have a screening tool that can be used in an acute care setting only. That would only benefit a certain subset of patients and clinicians working in those healthcare settings. We wanted to see also, could it be utilized just as accurately and just as well in a skilled nursing facility, for instance, or in an acute rehab setting, or in an outpatient clinic. So that was one of our goals. And then we wanted to develop a screening tool that could be used reliably by a number of healthcare professionals. Certainly speech pathologists, I would argue, are the preferred professionals in working with individuals with oral pharyngeal dysphagia, and certainly we work collaboratively with ENT. I understand I'm speaking to physicians, and certainly it's a team approach, but we're all not always necessarily staffing 24/7. And so for speech pathologists, if we're not there 24/7, it would behoove us to have other healthcare professionals, such as nursing, to be able to administer this screen and do so accurately. So one of the components of the Yale Swallow protocol is the 3-ounce water swallow test. And it's a test that had been around for a number of years. It was developed by DePippo and colleagues. So it's not a test that we developed. And it was a widely used, and still is a widely used, clinical screening tool to determine, again, risk of aspiration. As it was initially described, and I'll come back to this because we've actually changed the failure criterion for the 3-ounce test in our protocol, but as it was initially described, patients are asked to are given 3 ounces of water, and they're asked to drink the entire amount. So you hand the cup of water to the patient. They can use a straw, they can use a cup, either way. But you ask them to drink the entire amount without stopping. It's not a test of how quickly somebody can drink 3 ounces. So we don't ask people to chug 3 ounces. We don't ask people to drink as quickly as possible. Simply, I want you to take this. I want you to keep drinking until it's all gone. So 3 ounces. Failure is an inability to consume the entire 3 ounces without stopping. So for instance, if you have a patient that comes in, takes a sip, puts the cup back down, takes another sip, puts the cup back down, they drink the entire 3 ounces, but they stop, that's a failure on the 3-ounce water test. Additionally, coughing or throat clearing within 1 minute of test administration is considered a failure on the 3-ounce water swallow test. And if they fail, then that means that they need to go on for further testing. So in our initial study, what we wanted to do, we were interested in this 3-ounce test. We knew that this had been around and had been utilized for a while. There had been a number of studies looking at whether or not it accurately predicted or identified individuals who aspirated. However, most of those studies had been done with individuals who had dysphagia due to stroke. We wanted to see if we could expand the clinical utility of the 3-ounce test to patients who had dysphagia due to other diagnoses. Additionally, most of those studies had very small numbers of participants, so we wanted to look at a larger population of individuals at risk for dysphagia to see if the 3-ounce water swallow test accurately identified individuals who aspirated. So again, that was our first question. Does the 3-ounce test identify patients who aspirate? We also wanted to know if an individual failed the 3-ounce water test, did that mean that they were also unsafe for an oral diet? And conversely, does passing the 3-ounce test indicate an ability to tolerate an oral diet without the need for further instrumental assessment? And that was pretty revolutionary to consider that the possibility that if we give an individual 3 ounces of water to drink, and they do so without stopping or without coughing or clearing their throat within 1 minute of test administration, does that mean that we can then recommend an oral diet without the need to do any additional testing? But that was one of the questions that we had in this initial study. So in terms of participants, we included all endoscopic evaluations of swallowing performed from December 1999 to September 2006. At that point in his clinical practice, Steve Leder, who is the individual who performed all the endoscopic evaluations of swallowing for this study, he was doing endoscopy or fees on every single patient for whom he received a referral. So we had a large number of participants in this initial study. We had 3,000 participants, and you can see the breakdown of males and females. Ages ranged anywhere from 2 years, 2 months, all the way up to 105 years of age. And you can see we had very few missing data points. And again, because we wanted to expand the clinical utility of this test beyond just individuals who had dysphagia subsequent to stroke, we looked at a number of different diagnostic categories, 12, and you can see the breakdown here and the numbers of participants per diagnostic category for this initial study. We certainly did have individuals who had stroke, but again, we had individuals with other diagnoses as well. All of the subjects or participants completed endoscopic evaluation of swallowing, and then they completed a 3-ounce water swallow test. Part of doing research is setting about with one method and then realizing perhaps we need to improve upon the methodology. So this first study certainly has methodological flaws, one of which was the tester was not blinded. As I said, Steve Leder did all of the endoscopic evaluations of swallowing, and he did all of the 3-ounce water swallow tests, which certainly could introduce bias. It is a huge methodological flaw with this initial study, and one that I will readily acknowledge. Additionally, fees served as the criterion standard to which results of the 3-ounce water test were compared. There are a number of studies that have suggested that fees is every bit as, if not in some cases more, sensitive to determining or detecting aspiration than video fluoroscopy, but it certainly has been a criticism that we've received for this study is that we used fees as the criterion standard. So this is your typical 2x2 table that we utilize when we are determining sensitivity and specificity and accuracy of the test. So you can see that fees served as our criterion standard, whether or not the individual aspirated or didn't aspirate, and then we compared those results to the 3-ounce water swallow test. So positive means they failed, negative means they passed. And what should stand out on this 2x2 table are, there are two things that should stand out, one of which is the very low number of false negatives that we had. So out of 3,000 individuals that we gave the 3-ounce water swallow test to, only 24 had false negative responses, meaning that they passed the 3-ounce test, but on endoscopy they were found to be aspirating. So that's pretty good. 24 out of 3,000 is pretty good. It's not perfect, but it's a very low number of false negatives. The other aspect that should stand out to you here is the very high rate of false positives. And as I said earlier, it's considered acceptable with this screen to have a high rate of false positives. What you don't want is a high rate of false negatives. So we did have a lot of individuals who failed the 3-ounce water swallow test who were found not to be aspirating on fees. When we did the analysis, what we found was that we had 96.5% sensitivity in terms of identifying individuals for the 3-ounce test to identifying individuals who aspirate thin liquids. Specificity was quite a bit lower. Positive predictive value was quite low, but negative predictive value was quite high. So what we concluded was that a high sensitivity plus a high negative predictive value meant that the 3-ounce water swallow test was a good predictor of a patient's ability to tolerate thin liquids, such as water. However, because of the high false positive rate and the low specificity, that meant that nearly half, or we found that nearly half of the individuals who failed the 3-ounce challenge did not aspirate during fees. So thus, the 3-ounce water test over-refers individuals for instrumental assessment. But the benefit of the test is if the patient passes the 3-ounce test, they don't need additional assessment. So you're identifying individuals who are safe. However, you're going to over-identify individuals as being at risk for aspiration and then refer on for instrumental assessment. To answer our other question, does failure on the 3-ounce water test indicate an inability to tolerate an oral diet? Again, you can see on the on the top, unsafe for an oral diet was either a yes/no determination based on endoscopic evaluation of swallowing, and then we compared those results to the 3-ounce water swallow test. And again, what should stand out here is the very low rate of false negative responses. We only had 20 individuals that were deemed safe for an oral diet based on or passed the 3-ounce test and should not have been placed on an oral diet. But again, we had a very high rate of false positives. Again, when we did the analysis, we found quite high sensitivity, 96.4%. Specificity was lower. Positive predictive value was quite low, and then negative predictive value was quite high. So our conclusions were that a high sensitivity plus a high negative predictive value meant that passing the 3-ounce test was a good predictor of a patient's ability to tolerate an oral diet without the need for any additional testing, which again was pretty revolutionary. Low specificity plus a high false negative rate meant many patients were recommended nil by mouth status unnecessarily and would thus be referred on for further assessment. So again, as I said, part of research is learning and learning from, as you get in the middle of it, how to improve upon your methodologies. So some of the caveats with this initial study were that the tester was not blinded. The results were based only on these results and not video fluoroscopy. The results were based on an SLP administering the screening test initially. And again, one of the goals of our research was to determine whether or not other individuals, other healthcare professionals could administer this screen. So in this initial test, we only looked at SLPs. Certainly we needed to go on and look at other healthcare professionals administering this test. And the studies were based on a referred sample rather than a consecutive sample, meaning that these were individuals who had been referred to speech pathology for a dysphagia evaluation because they were already considered by a physician that made the referral as being at higher risk for having dysphagia. And so it's possible that that was a flawed referral. Certainly it could have either over-identified, over-referred, or under-referred individuals. And we don't know that. So again, it was a referred sample. We did not screen every single individual in the hospital. So for the next step in our protocol development, we had been collecting data all along on patients, and we had an awful lot of information. One of the typical aspects of a speech pathology evaluation is that we ask patients orientation and command and ask them to follow commands. I think that's part of pretty much everybody's assessment. But we didn't have a lot of information suggesting that that gave us any benefit in terms of, we didn't know what it told us about the patient other than that they were alert and oriented and they could follow commands. But did that have any bearing on whether or not they were safe for an oral diet? So we were interested in that. We wanted to know if ability to follow commands and a patient's orientation status affected the odds of aspiration. Again, this was a referred sample. At this point, we had 4,070 patients, 3,000 of whom were in that initial 3-ounce water swallow test study, and you can see we continued to collect data. The ages for this study were 10 years to 105 years of age, because 2-year-olds typically can't answer orientation questions. You can see the breakdown of males to females, missing data, and at this point we had 14 different diagnostic categories. In terms of orientation, it's the simple person, place, time. What's your name? Where are you right now? What year is it? Command following is done in conjunction with an oral mechanism examination, and because this is a screen, it's a very brief oral mechanism examination, which we ask the patient to open your mouth, stick out your tongue, and smile. Swallowing was then assessed with fees. And what we found were that the odds of liquid aspiration were 31% greater for individuals who were not oriented than for those who were. And the odds of liquid aspiration were 57% greater for those who were unable to follow commands. So does that mean that everybody who's not oriented times 3 is going to aspirate, or everybody who can't follow commands is going to aspirate? Certainly not. It's a piece of information. It tells you a little bit more about the overall status of your patient. So it's useful information. It does speak to the odds of aspiration, but certainly it needs to be taken into consideration with the overall presentation of your patient. So that was orientation and command following. As I mentioned, we were also doing an oral mechanism examination, and that's been part of a speech pathologist standard examination for years. But again, we didn't have anything in the literature suggesting that it gave us any beneficial information in terms of the patient's swallow ability. So we were interested in determining whether results of an oral mechanism exam, and again, it's a very, very brief oral mechanism examination. This is not a full cranial nerve examination by any stretch of the imagination. But we wanted to look at lip closure, lingual range of motion, and facial symmetry. We had 3,919 participants. You can see the age range from 2 years to 105 years of age, 14 different diagnostic categories, and we did an oral mechanism examination followed by fees. And what we found was reduced lingual range of motion was associated with an increased odds of aspiration. That makes sense. If a patient can't move his or her tongue very well, they're going to have trouble controlling food and liquid. They are at increased risk of aspirating, and we found that participants with decreased lingual range of motion had 2.72 times the odds of aspiration as those with adequate lingual range of motion, and decreased lingual range of motion was an independent risk factor for aspiration. It was the only aspect of the oral mechanism examination that was predictive of aspiration risk. So taken together, those 3 studies are then what we put together to make what we now call the Yale Swallow Protocol. So the Yale Swallow Protocol includes this brief cognitive linguistic screen, which looks at orientation status, orientation times 3, person, place, and time, command following ability, which is one-step commands that we assess in conjunction with the oral mechanism examination, which looks at facial symmetry, lingual range of motion, and lip closure, and then the 3-ounce water swallow test. When we give the 3-ounce water swallow test, the criterion that we now use are, we want you to, it needs to be continuous, so you need to drink 3 ounces without stopping. If you stop, if the patient stops, takes a sip, stops, takes another sip, stops, that's a failure. Or if they cough immediately after. We've said immediately after because what we were finding is if we waited up to a minute after test administration, we were having a lot of patients that would cough or clear their throat, 45 seconds after we'd given the 3-ounce water swallow test, and it didn't have any, it was not indicative of the fact that they were aspirating. We were getting a high rate of false positives, or a higher rate of false positives, when we waited for a minute. So we have now said immediately after the 3-ounce water swallow test. So hopefully this video is going to work. This is me and one of our students doing the Yale Swallow Protocol. So I'm going to try to get it to play. Today I'm going to show you how to administer the Yale Swallow protocol. The first step in the protocol is a brief cognitive linguistic examination consisting of simple orientation questions. So, Liesl, can you tell me your full name? Liesl Morris. All right, and what year is it right now? 2017. And where are we right now? Fantastic. The second step in the Yale Swallow protocol is assessing an oral mechanism examination, and at the same time, we're assessing the patient's ability to follow one-step commands. Let me have you open your mouth. Good. Stick your tongue out at me. Good. Wiggle it from side to side. Good. And then smile. Good. And pucker. Good. Fantastic. All right. And then the third step in the protocol is administration of the 3-ounce water swallow test. Failure criteria for the 3-ounce water swallow test are going to be an inability to consume the entire 3 ounces without stopping or coughing immediately after test administration. So, Liesl, I would like for you to take this. And what I'd like for you to do is drink that all continuously without stopping, okay? Good. And that constitutes a passed 3-ounce water swallow challenge. Therefore, that's a passed Yale Swallow protocol. So that's just a very brief video on how to do Yale Swallow protocol. I did include the administration form just in case anybody was interested in that as well. So there are some populations that we would suggest not utilizing Yale Swallow protocol. And those include patients with tracheostomy tubes. And the reason for that is because we are concerned that there is a higher risk. There's some research by Sasaki and colleagues, for instance, that suggests that individuals who have trach tubes in, particularly for prolonged periods of time, have decreased sensation at the level of the vocal folds. Therefore, they're more likely to aspirate silently if they do aspirate. So therefore, we don't recommend use of Yale Swallow protocol with those individuals, although my understanding is that there is a group right now studying that because it's been an assumption that we made, but we have never actually trialed it with patients with trach tubes, so that remains to be seen. Additionally, patients with head and neck cancer who have undergone radiation treatment, we have suggested that we should not use Yale Swallow protocol with those individuals because, again, we are worried about desensitization at the level of the glottis, and therefore we wouldn't recommend that. Certainly if a patient is not alert and awake, I wouldn't recommend handing 3 ounces of water to them if they're on non-invasive ventilation and they desat as soon as, for instance, you remove the face mask. I wouldn't necessarily recommend giving a Yale Swallow protocol. High flow nasal cannula, perhaps I wouldn't suggest using Yale Swallow protocol. So there needs to be some clinical judgment that goes along with administering this, but these are the specific patient populations for whom we have said we should not use Yale Swallow protocol. So as I said, we had a lot of data, and part of the research process is learning as you go. And so in order to improve upon the methodology for the initial test, we did an additional study looking at validation of the whole Yale Swallow protocol, so the orientation and command following, the oral mech, and the 3-ounce test. The individual administering Yale Swallow protocol did not do the instrumental assessment of swallowing, which in this particular study was video fluoroscopy. So each individual was blinded to results of either the screen or the instrumental assessment. And we actually had quite similar results. We had actually 100% sensitivity on that particular study, quite a low number of participants in that study. But we felt as if that was good corroborating evidence for utility of Yale Swallow protocol. As I mentioned earlier, we wanted to know if other healthcare professionals could administer this protocol. So in 2013, we did a study where we compared results of nurses administering the Yale Swallow protocol to speech pathologists administering the Yale Swallow protocol. And what we found was that nurses with training, and it was a video training, with training, nurses certainly can administer Yale Swallow protocol. So that was a benefit of that we found for Yale Swallow protocols. Other healthcare professionals certainly could do that. One of the questions that we've received quite a bit is, how do you know? So we've given 3 ounces of water to somebody. That doesn't seem like a complete assessment of swallowing, and it's not, it's a screen. But we wanted, one of the questions was, how do you know that those results are accurate? Did you follow these individuals? And so we did a study where we followed individuals for 5 days in an acute care setting, which in an acute care setting, 5 days is really about as much as we could go out before patients were being discharged. And we looked at patients who had passed Yale Swallow protocol, who were recommended an oral diet. We looked at percentage of intake, and we looked at pulmonary outcomes. And what we found was that patients that were recommended an oral diet following Yale Swallow protocol were tolerating those diets and did not have any, within 5 days, any acute medical conditions specifically related to inability to tolerate their oral diet. So we felt good about that. We don't have those kind of data for instrumental assessments of swallowing, but again, we have those data for this protocol. We wanted to look, as I said earlier, at utilization of Yale Swallow protocol, not just in acute care, but across a number of different healthcare facilities or settings. And so we've looked at it in ICU and step-down units. We've looked at it in skilled nursing facilities. And we've actually looked at it in acute rehab as well. One of the big uses of this protocol that is a study that we just published last year was utilizing Yale Swallow protocol in individuals post-extubation. So one of the questions that has circulated for years amongst speech pathologists is, how long do we need to wait after somebody is extubated in order to evaluate their swallowing? So this study had a couple of different purposes, one of which was to determine if Yale Swallow protocol could be utilized in individuals following extubation, but we also wanted to know, how long do we need to wait after somebody's extubated to assess. And so what we did in this particular study, what Steve did, was within 1 hour of extubation, he was at bedside administering Yale Swallow protocol with these individuals. If the patients passed, they were recommended an oral diet. If they failed, he went back at 4 hours post-extubation. Same thing, if they passed, they got an oral diet. If they failed, they were recommended an NPO until he went back at 8 hours post-extubation, or 24 hours, I'm sorry. And so what he found was the vast majority of individuals actually passed Yale Swallow protocol within 1 hour of extubation. Again, they were followed up after they were put on an oral diet at that point, and they were followed up for several days, and they were tolerating an oral diet. So in that study, we found that Yale Swallow protocol worked well for those individuals. And I know right now, in the age of COVID, where people are being intubated for prolonged periods of time, that's a question that a lot of individuals are having, is how do we assess these individuals? How do we assess these individuals and not put ourselves at risk? And is there a way to screen these individuals, because it's difficult for those individuals to go to the fluoroscopy suite, or there are concerns about completing endoscopy or endoscopic evaluations of swallowing with those individuals. Honestly, I don't know, and I don't know that I would be comfortable suggesting to use Yale Swallow protocol for somebody who's been intubated for longer than 2 weeks, which I understand many of those individuals with COVID are. We simply don't have those data, so I don't know the answer to that question. Certainly, without going too much into post-extubation dysphagia, there's evidence that the longer that somebody's intubated, that the more likely they are to aspirate silently if they do so. So I wouldn't necessarily recommend Yale Swallow protocol for individuals who've been intubated for these really prolonged periods of time. It's a question I've gotten a lot, but I don't have an answer. Finally, what we did was, there was a group of researchers that got together, and we were interested in determining the utility of water swallow protocols. And so when you look at screening protocols, certainly ours is not the only one available. There are a number of them. If you do just a Medline search for a screening protocol for dysphagia, it will yield hundreds and hundreds. And you'll hear healthcare facilities saying that they want to develop their own unique protocol. They don't want to use one that's already been developed. We were interested in looking at water swallow protocols to determine the accuracy of those protocols. And when you look at water swallow protocols, there are some that include very small boluses, such as 5 ml. One of the criticisms we've received for Yale swallow protocol is that 3 ounces of water is an awful lot. Aren't you worried about people aspirating large volumes of water? And so some people have suggested we should be using much smaller boluses, such as 5 ml, which is about a teaspoonful of water. So we looked. I am an author on this study, but I was not involved in the data analysis. But we looked at all published protocols that included a water swallow test, some of which included 5 ml, some all the way up to some that included actually 100 milliliters of water, to determine which one had the best accuracy in determining who was aspirating. And what we actually found was that water swallow protocols that included a larger bolus volume, so 90 milliliters, which is 3 ounces or more, were more sensitive than those that included a very small bolus, such as 5 ml. So basically the take-home message from that systematic review was, if you use a small bolus such as 5 ml, you're going to have very low sensitivity. You're going to have a lot of people who are going to not cough, not fail with 5 milliliters, that if you gave the same individual a larger bolus volume, such as 90 milliliters, they would fail. So you're going to miss a lot of people if you only give a very small bolus volume. It's necessary to give a larger bolus volume so that you don't under-identify individuals who are at risk for aspiration. So that was a systematic review that we published. And there have been subsequent studies that have corroborated that finding. You have to use a larger bolus volume. And certainly if a patient is coughing during administration of the 3 ounce test, we stop them. We don't say you have to absolutely drink all 3 ounces. If they cough, we're finished, we're done. We don't keep pushing them to consume the entire 3 ounces. So that's something that you need to think about. And we're not just forcing them to drink 3 ounces of water. If they are showing signs of struggling, we stop them, and that's a failure. We go on to further assessment. So in terms of conclusions, and I see my T got cut off. The Yale Swallow protocol is a valid, easy to administer, evidence-based protocol to screen for aspiration risk. Again, we looked at this across a number of patient populations, across a number of healthcare settings, and with individuals other than speech pathologists administering this protocol. And we have found that Yale Swallow protocol is valid and in identifying individuals at risk for aspiration. As I said, it's been used across multiple healthcare settings and with multiple patient populations at this point, and has been found to be useful and accurate in identifying individuals who aspirate. And I can see that I am finished a little bit early. I don't know if there are any questions. I don't know if anybody else is joining me at 8:47 in the morning on a Friday morning before Memorial Day weekend. Certainly if there are questions, I'm happy to answer them. If not, certainly I would welcome, if anybody has questions, you're always welcome to contact me at UK. Certainly I can include that information in the slides that I will share. So thank you for listening. I'm going to stop my screen share.